Thank you, Dr. Patrick, for this wonderful talk. I now take the opportunity to invite Dr. Mark Jensen for his lecture. Dr. Mark Jensen is a PhD in psychology from University of Washington. He also has been involved in various researches, particularly in rehabilitation medicine. He has been developing and studying the efficacy of psychosocial pain treatments and facilitating national and international workshops on these treatment approaches for the past 3 decades. His clinical work combines cognitive behavioral, hypnotic, motivational approaches to help patients overcome the chronic pain and improve their quality of living. Dr. Jensen did his PhD from Arizona State University. He has various research programs in his hat, and he has been teaching at University of Washington. Today's topic for Dr. Mark Jensen is hypnosis for pain management. I welcome you, sir.
Thank you so much for inviting me. I'm so happy to be here today. There we go. Excellent. Okay, so there we go. So today we'll be talking about hypnosis for chronic pain management. And I'm again incredibly honored to be here on this first day of the declaration of the Academy of Hypnosis India. I'm terribly excited to be a part of the beginning of this new society and the expansion and use of hypnosis in India. In today's talk, I'm going to do several things. First, I'm going to talk about chronic pain as a significant problem in the world. And then for those of you who are new to hypnosis, I understand that there are some that are here. I'm just going to give you a small taste of the effects of suggestion. And then talk about 3 clinical studies that support the efficacy of hypnotic analgesia. Talk about imaging studies supporting the efficacy of hypnotic analgesia, and then the implications of these findings for the treatment of chronic pain. Really the idea underlying this whole program is that peripheral activity may trigger pain, but ultimately it is the brain that creates our experience of pain. The final common pathway is the brain. The primary pain generator is the brain. And so treatments that impact brain can produce pain relief. That's the whole idea. Now, those of you who work in the field of health know that chronic pain is a significant problem worldwide. 15 to 20% of people at any one time experience chronic pain. And in terms of widespread pain, like fibromyalgia, it's 5 to 7%. Neuropathic pain, it's 3 to 8%. It's a big problem that has significant and negative impacts on people, their families, society, and costs. And unfortunately, the primary treatment that's provided for people with chronic pain are medications. And the problem is that even our most powerful medications, opioids, only provide 32% relief on average. These are not painkillers. There's no such thing as a painkiller. At best, they're pain relievers slightly, but of course they have many, many negative side effects. In terms of response to neuropathic pain, opioids provide, again, just 35% relief. So there is a need for alternative treatments for pain. And so we've moved in the direction of hypnosis to help with that. So again, if you don't have experience with hypnosis, I'd like to invite you to experience just slightly a taste of suggestion. I'm going to invite you to imagine a taste and invite you to imagine a heavy hand. And if you don't want to do it, fine, it's completely voluntary. So when I invite you to experience a heavy hand, I'm going to invite you to put your a hand out in front of you with your palm up. So go ahead and get yourself in a comfortable position. And then when you're ready, if you'd like to participate, take a nice deep breath and hold it. Hold it for a moment and then let it go. Allow the eyes to close. And now imagine yourself in your kitchen. In your mind's eye, you can see yourself there in the kitchen. And you can picture in front of you a lemon on a chopping board. And you can see the yellow of the lemon. And you take a nice knife and you slice that lemon in half, smelling the citrus. And then lifting the lemon up to your mouth, taste the lemon, actually taste it. That's right. And then your mind's eye, go ahead and allow your hand to go in front of you with the palm up. And then picture a very heavy object in that hand. Place that heavy object in that hand. Perhaps it's a very large, heavy book pushing down on the hand. And then put another object on top of that one, 2 heavy books. Heavier and heavier and heavier. And then 3 books, allowing the heaviness to go down, allowing the hand to drop. And then come back to the here and now. Okay, so I imagine that some of you actually experience the tasting of the lemon, some of you maybe less so. Some of you experience the hand being heavier, some of you less so. That's the thing about this, is that the effects for those who experience it are very real to them. The lemon is not there, and yet a large group of us actually pictured some yellow. We created that experience of yellow in our mind. We created the sense of the taste of the lemon. Those are very real to us. And the effects are variable. Some of us experience stronger effects than others. People vary in their ability to experience and create new experiences for themselves with their mind. So what you might ask yourself, what was happening in our brains during that experience? Well, a very interesting study was done back in 2004 by Stuart Derbyshire and colleagues. What he asked the question, is it possible to use hypnosis to induce pain? And he asked the question, does hypnotic pain, pain suggested during hypnotic procedures, differ in any way from imagined pain or from real pain? By real pain, that is pain produced by noxious stimulation. And so what he did was he had these different conditions and then measured the pain intensity and cortical activity in the brain in response to painful heat, hypnotic pain, and imagined pain. And when pain was the result of dipping the hand in hot water, the average pain intensity was about 5.5 out of 10, but some had more. Some had much more, some had less variability. And following a hypnotic induction in which they actually suggested to the participants in this study that they experience that pain, the pain intensity they reported was less on average, a little less than 3, but that pain was present. When they invited participants to imagine pain, they said, yeah, I can imagine it, but it doesn't really feel like pain. It's 0 out of 10, but I can sort of imagine it. So in fact, you could, with real stimulation, with noxious stimulation, 5.7 out of 10, hypnotic pain, 2.8 out of 10, imagined pain, 0 out of 10. What happened in the brains of these participants during these 3 conditions? Well, here on the far left was the brain activity during noxious stimulation, hand dipped in hot water. all the areas of the brain that light up and are active when we're experiencing pain lit up and were active. When the person imagined the pain, this third column over, those same areas kind of glowed, but did not light up as strongly. This is 0 out of 10 ratings. And then following a hypnotic induction in which the person was suggested to experience the pain, those same areas became active, somewhere between those two. And again, the intensity of the pain reported was about half. So the results of this study indicate that people can imagine pain, and when they do, the same areas of the brain that are active when a person's experiencing pain with noxious stimulation kind of light up a little bit. But when hypnotized, many people can imagine pain as if it were real. They can actually experience the pain. Not everybody, but a substantial subset of people. And these effects can be seen on fMRI. The effects are real in that way. It's nothing made up. And the practical application, of course, is that if you can use hypnosis to create the experience of pain, you may be able to use hypnosis to create the experience of comfort. So Stuart Derbyshire followed up with this in a study in 2009 and asked the question, what are the effects of hypnotic analgesia and just suggestions for comfort on pain and activity in the brain? So again, they took a set of people, in this case, people with chronic pain, and they asked them to rate their pain intensity. And then they invited them to imagine the pain is higher and imagine the pain is lower, and asked them to rate their pain, and then did a hypnotic induction and suggested that the pain were lower and the pain were higher. This was a group of people with fibromyalgia. And this is what they found. Average pain was about 5.5 or so. And when people imagined or were suggested that the pain be less, pain was substantially decreased. And when they imagined or were suggested the pain be higher, the pain was substantially increased. And these effects were larger in individuals who were hypnotized. So again, people respond to suggestions, both hypnotic and non-hypnotic, but the response is stronger following a hypnotic induction. Doing the hypnotic induction makes people more responsive to suggestions. So what were the effects on brain activity? What did we see? Again, with the hypnotized patients, we saw more activity in these areas of the brain that light up when a person is feeling pain. Unhypnotized, some, but less. So the evidence indicates that indeed our brain is a final common pathway to our experience. We create everything that we experience, including anxiety or calm or depression or love or hate. We create this experience, and we can use hypnosis to enhance our ability to alter our experience, including bringing people with chronic pain comfort. So my interest, of course, is in the use of hypnosis for treating chronic pain. And I started out my area by conducting a clinical trial. This was a randomized controlled trial of training people to use self-hypnosis to manage their pain. And my control condition was EMG biofeedback, just teaching them how to feel more relaxed. The group was people with spinal cord injury and chronic pain. This was a study funded by NIH, National Institutes of Health. And the questions we wanted to address were, what percent of people with spinal cord injury related chronic pain benefit? Up to that time, there were many case reports, and all of them were astounding successes. But the question is, what happens when you give the same standardized treatment to a group of people? What percent actually benefit? And do the benefits last beyond the sessions? How long do they last? And finally, is self-hypnosis training more effective than a viable alternative treatment that raises the same level of expectations? So we took 37 people with spinal cord injury and chronic pain and assigned them to either a hypnotic condition or EMG-assisted biofeedback relaxation condition. We gave them 10 sessions of treatment. These days, I give 4 sessions, but when we started this program of research, we wanted to make sure we'd be effective, so we started strong. And we assessed outcomes before and after treatment and at 3 months follow-up. These were people with spinal cord injury, average age about 50 years, mostly males, because males tend to get spinal cord injury more than females. 95% white, 5% Native American, about half and half neuropathic pain and non-neuropathic pain. And 76% of the people completed treatment. Outcome, the primary outcome was usual pain intensity. We measured this by asking the participants to rate their average pain in the past 24 hours 4 times within a 1-week period. So we wanted to get a sense of their overall average pain. We did this at before treatment, post-baseline, post-treatment, and 3-month follow-up. And we averaged those 4 ratings into a single score representing average pain. And outcome was assessed by a research assistant who was blind to treatment condition. We also measured pain intensity before and after each treatment session. And then after treatment, we asked them to indicate how often they practiced this hypnosis and the number of days and the impact of that practice on their comfort. The treatment was involved of a hypnotic induction. It was a variant of Joseph Barber's rapid induction analgesia. And then we used a whole variety of suggestions to help them get pain relief. So we invited them to go to their special place that was their safest and most comfortable place. And then we made suggestions for being less and less bothered by sensations, sensations becoming less and less clear, imagining anesthesia, areas of discomfort engulfed and infused by powerful psychological anesthesia, a sensory substitution, noticing feelings like numbness or comfortable warmth in areas that used to be uncomfortable, feeling of deep relaxation, because feeling relaxed is inconsistent with experiencing significant pain, and in every case, post-hypnotic suggestions, making the suggestion that anytime the person wants to feel more comfortable in the future, they can use these skills, use a cue to experience that comfort, and the benefits of the session and practice will stay with them and become permanent. We gave each participant an audio recording and encouraged them to practice by listening to the audio recording daily, and also to practice self-hypnosis on their own 3 to 5 times every single day. The control condition was EMG-assisted biofeedback using frontalis EMG biofeedback to reduce frontalis muscle activity. And these participants were given an audio recording to use for home practice as well. And both of them treatments were described in the same way. Interventions that contain both relaxation and hypnosis components that have been shown to reduce pain in other populations. We wanted to elicit the same level of outcome expectancies. Okay, outcomes. Pre to post session, in both conditions, people reported a decrease in pain from pre to post sessions. Both have immediate impact on a person's pain intensity. However, in terms of daily average pain, only the hypnosis condition showed a statistically significant decrease from pre to post treatment, which maintained at follow-up. The responders who had reported a 30% or more reduction in pain, in general, that's the amount of pain relief people describe as being meaningful to them. 22% of those in the hypnosis condition and 10% in the biofeedback condition were treatment responders. Now, this is significant because people with spinal cord injury pain find that nothing helps them with their pain. So this was finally found a treatment that helped at least 1 out of 5 people with spinal cord injury and chronic pain significantly. And at 3 months follow-up, 60% were still listening to the audio recording, 60%. And 80% said they continued to use their hypnosis skills without the recording. Again, even though only 22% reported significant meaningful reductions in their chronic daily pain, 80% continued to use the skills. And you might ask, well, so why did they continue? Well, the reason was that when they used their skills, they reported significant relief. So many of these participants were using self-hypnosis as a way to get immediate relief that didn't necessarily last all day or forever, but gave them relief. They used it kind of like a safe medication. And the average hours of relief, for example, was 3. So the conclusions from this study, which was my first clinical trial in this area, was that both hypnosis and biofeedback have similar immediate and substantial effects on pain intensity, but that hypnosis is more effective than biofeedback for daily average pain. Those decreases associated with hypnosis maintained for at least 3 months, and treatment is variable. Not everybody benefits, but 80%, a whopping 80% continue to use the skills taught at 3 months and report pain relief when they do that lasts for 1.5 to 3.5 hours. 80%. We subsequently did a study with multiple sclerosis, comparing hypnosis to progressive muscle relaxation, and had the same outcomes. That is, those who got self-hypnosis training reported significant decreases in pain from pre to post treatment that were not seen in those who got the muscle relaxation training. Now, this was multiple sclerosis, which is easier to treat than spinal cord injury pain. So about close to 50% of the people were treatment responders in the hypnotic condition, 14% in the progressive muscle relaxation condition. Now, we were curious about why were so many people using self-hypnosis at 3 months, even though many reported that they didn't have meaningful or very large decreases in pain intensity at that time. So we asked them, what do you get out of hypnosis? What are the effects that you get? And 40 different effects were listed by these 30 participants. 9 of them, only 23% were pain related. Almost 60% were non-pain related benefits with hypnosis treatment focused on pain. 13% were neutral, and just 3 were negative. Okay, what were these? In terms of the pain related benefits, as you'd expect, people reported pain reduction, a sense of increased control over pain, and a feeling that I have a new tool. I have something in my toolkit that I can use to manage my pain. The non-pain related benefits included general positive comments, it helped and I liked it, an increased sense of overall well-being, increased feelings of relaxation, and decreased stress. The only negative effects reported, one person said it did not work for me. Another person said it wasn't as effective as I hoped it would be. And another person said the effects did not last as long as I hoped. These were the worst things that people said about this treatment. So now imagine a drug that produces substantial decreases in pain in 22% of spinal cord injury patients with chronic pain, 47% of people with multiple sclerosis and chronic pain, and that drug's side effects are overwhelmingly positive, including an increased sense of well-being and relaxation. And that drug, the worst side effects are very rarely, it has no effect, or not as effective as hoped, or the benefits do not last as long as hoped. Such a drug, and continues to be effective, has no tolerance, and 80% of the people continue to use it. This would be a blockbuster drug. It would probably be a drug that people would go to first before trying any other drug for chronic pain. Okay, so since we did those trials, other trials have been conducted, and the reviews are consistent. Saying conclusions, hypnotic analgesia for chronic pain is more effective than no treatment, and more effective than some biomedical treatments, including physical therapy and medications. Hypnotic analgesia has specific effects over and above expectancy, and response is variable. Some people get an incredible amount out of it. Some people get less, most people are in between. Okay, so that's using hypnosis to treat pain directly. There's also evidence to suggest that you can use hypnosis to enhance the treatment, the efficacy of other treatments. This idea is based on, that we had for pain, is based on a review conducted by Irving Kirsch and colleagues in 1995, in which they looked at what's the effect of adding hypnosis to cognitive behavior therapy. And what they did a meta-analysis of 18 studies comparing CBT with CBT plus hypnosis. And they found that adding hypnosis substantially enhanced outcomes, an average effect size of 1.36, which is huge. A large effect size is 0.80. So 1.36 is huge. These effects are the strongest for treatment of obesity and for long-term follow-up. And these results were replicated and extended in a recent review of the literature that looked at studies since that 1995. So this is a very reliable finding. And this slide shows an example of one of the studies. CBT for weight loss, average weight loss of about 8 pounds that's maintained, perfectly acceptable, perfectly good. But when you add hypnosis, the weight loss goes to 22 pounds and maintains. So adding hypnosis increases the efficacy of CBT. And we wanted to look at, what if we did this for chronic pain? What if we added hypnosis on top of or with CBT for chronic pain? And we started out with a pilot study. We gave 4 sessions of an education control condition, cognitive therapy, hypnosis, and combined hypnosis and cognitive therapy. This was 16 patients with multiple sclerosis and chronic pain. And we measured pain intensity, pain interference, and catastrophizing before and after each of these different treatment modules. So what happened? In terms of pain intensity, with education, slight drop, not big. With cognitive therapy, a drop of 0.23 effect size. That's a small effect, and that's consistent with the literature. Cognitive therapy for pain generally changes cognitions and mood. Pain intensity, not so much. Hypnosis focused on pain reduction, a half a standard deviation unit, that's considered a moderate or medium effect. Meaningful and significant. Now, hypnosis focused on changing beliefs and thoughts about pain, those mistaken beliefs and the mistake of believing those beliefs that Patrick talked about, almost 1 standard deviation unit. And this is very interesting. The hypnosis focused on changing pain beliefs decreased pain intensity almost twice as much more than hypnosis focused on pain reduction. Let's think about that, and we'll talk about that later. But this surprised us. And in terms of pain interference, we got the same pattern of effects. No change with education, very slight change with cognitive therapy. Hypnosis focused on pain reduction didn't affect pain interference so much, but hypnosis focused on beliefs about pain doubled the effects. They had a much larger effect size. The effect on catastrophizing, same pattern. Education, a slight drop. Hypnosis focused on pain reduction, medium effect. Cognitive therapy, which really focuses on catastrophizing negative beliefs, larger effect, but the largest effect was hypnosis focused on beliefs about pain. So we wanted to look at this more carefully, and we got funding to do a larger study. This is an ongoing 4-arm randomized controlled trial in which we're looking at pain in people with a variety of conditions, including spinal cord injury, multiple sclerosis. In this case, people are randomly assigned to 4 different treatments, and we measure pain intensity, depression, and pain interference before and after treatment. And again, the research assistant is blind to treatment conditions, so that's an unbiased measure of outcome. Average pain intensity with education about pain, a drop. When people are given intensive information about how pain works, they sometimes feel more pain relief. Cognitive therapy, similar drop. And hypnosis focused on pain, similar drop. But hypnosis focused on beliefs about pain was substantially more, almost double the effect size. Same pattern with pain interference. Education and cognitive therapy, we see a drop. Hypnosis focus on pain, a drop, but much larger effect, hypnotic cognitive therapy, much larger. So the bottom line is that hypnotic cognitive therapy doubles the efficacy over cognitive therapy alone, or hypnosis focused on pain reduction on outcome, doubles the efficacy. And you might want to know, you ask the question, why? What is it about hypnotic cognitive therapy that makes it so much more effective than hypnosis focused on pain reduction or regular cognitive therapy? What's wrong with just plain old cognitive therapy? As my colleague Michael Yapko likes to say, it's just too cognitive. It doesn't take advantage of the increases in cognitive flexibility produced by hypnosis. When you add hypnosis, you make the brain more plastic, more able to change. What's wrong with hypnosis focused on pain reduction? What is it focusing on? Pain. So yes, you can tell the elephant is getting smaller and smaller and smaller, and yes, you see some effects, but the elephant is still there. You're still inviting people to imagine their pain first and then decrease it. What's right about hypnotic cognitive therapy is that it focuses on life. You invite people to focus their attention on what's important to them, their own life. And as this increases, it takes over and replaces the more negative. Okay, so what are the clinical implications of this research? First, you want to avoid negative suggestions. Patrick was explained this beautifully in the talk beforehand. Don't think of an elephant. Invite somebody to think of an elephant. Those who are parents, you tell your child, don't put your finger in the socket. You know what your child is going to do. There was a fun news report that illustrated this. A high school student, Travis Williams, was bitten by a baby rattlesnake in May, even though a companion had told him, don't do it, avoid that snake. And he said, even though she told me not to, I picked it up. I'm not too bright that way. But Travis is like all of us. You'd be told not to do something, you'll start thinking about doing it. That's just how it works. Also, you want to avoid this nasty word, try. Try, as Patrick pointed out, means to make an effort and to fail. So in our work with patients, we want to avoid telling them to try to exercise more, try to smoke less, try to eat more vegetables. Instead, we ask the questions, I wonder how you might exercise more, how you might become a non-smoker, how you might eat more vegetables in your life. Also, it's useful to incorporate hypnotic language in your day-to-day language with your patients, even if you don't use formal hypnosis. Just asking questions like, would you like to feel better? Or imagine feeling stronger. Imagine how you would do that. You might be surprised to experience how effective this treatment is. And you can use rhetorical questions implying a focus. Are you aware of how comfortable you can be? Let yourself notice the comfort. How would you feel if you were exercising every day? Also, you can use truisms. Sooner or later, you will be more comfortable. That's just simply true. And it installs this positive suggestion. I wonder how you are going to benefit from this treatment. And everybody knows that you get stronger with exercise. So giving an injection, consider saying this might hurt, or we're about to give you the prick, versus I think you're going to be pleasantly surprised at how comfortable this can be, how it becomes easier and easier. So the whole idea is to change focus, and you can do it with hypnotic language. You can do it with positive suggestions in or out of a hypnotic context. In the hypnotic context, the effects of suggestions are going to be larger. Okay, so to summarize then, chronic pain is a significant problem. Hypnosis can reduce pain intensity and the negative impact of pain, and it can enhance the efficacy of other pain treatments. These effects are strong. You can double the effect of other treatments by adding hypnosis to it. So after hearing this talk, and if you're new to hypnosis, you might ask yourself where to go from here. One is, well, that was interesting, but not for me. That's fine. Or you might start to find yourself experimenting with using hypnotic language with your patients to see the benefits of this. You might consider getting more formal training in hypnosis. For example, attending the Hypnosis World Congress in Krakow in 2 years, or become an active member of the Academy of Hypnosis India, and then participate in training workshops, becoming more and more involved in the society, and as a result, becoming a more effective clinician, and in time, facilitating training in workshops for others. I want to acknowledge funding for my research from a variety of funding sources. And I hope you have some fear about hypnosis, that now you feel much more comfortable with the idea of using hypnosis in your practice. And thank you very, very much.
Thank you very much, Dr. Jensen. It was a wonderful scientific way of presenting hypnosis and bringing the notice to the results, which are statistically significant. I thank you very much for this wonderful presentation.